Okay, guys. So I know we're running late. So I have 9 cases with associated learning points to work through. This is just from ID board review, highlighting that 15% of boards is HIV, and about 5% each are HIV treatment regimens and opportunistic infections. So it's relevant. This is a slide from the National HIV Curriculum about the mechanisms of action. My goal in this lecture is not to give the intro to ART lecture that you guys have gotten many times before. Whether or not you remember all the details is a separate topic. But my goal is to make this more of a practical approach to things that come up in clinic where we don't know what to do with their ART or where there's a decision to be made, and sort of use the guidelines and the available data to help guide us in those situations. While many of your patients are on Biktarvy, there are a lot of other options for ART that are approved. So this is just to give you an idea of how many there are. And these are all from ID board review, by the way. And I like the one that shows the different single tablet regimens. I think it's a nice slide to come back to. And then I also like that it points out that some of these regimens that you guys are really familiar with are not that old. So Biktarvy up there is from 2018. So sometimes you'll see people on other regimens and you sort of wonder why. Often it's because when they started ART, like Biktarvy wasn't an option, so they started something else and they've been doing well, so they've just continued it. And as we go through, as I said, I'm going to skip some of the basics in this lecture. If you feel like you need more basics, these are 2 resources I would direct you to. The top one is the HIV guidelines, hivclinicalinfo.gov. And the bottom one is the National HIV Curriculum. Have any of you guys opened that? Okay.
Yeah. Yeah.
Good. So a lot of images and things in this lecture come from that national curriculum because it's just really well done. It's really practical. It's really like digestible amounts of information.
And the handouts I bring to you guys are from that national.
Perfect. So maybe if you guys have all reviewed that, you're going to just know all of this and this lecture will just fly by. So let's see. Jess, you want to do the first case?
Sure. 28-year-old man is newly diagnosed with HIV and starting ART. Labs-wise, his antigen antibody screen is reactive, HIV-1 antibody reactive, viral loads 1.5 million. Core antibody, Hep B core antibody non-reactive, surface antibody non-reactive, and antigen non-reactive, creatinine of 1, and a CD4 count of 350. Which of the following are recommended first-line treatment options appropriate for this patient? Select all that apply.
And before we go into that, the boards will not give you brand names. The boards will give it the way it's written here. But your patients do not give you it the way it's written here. So you have to know both. Be honest.
Yeah.
So A is Biktarvy.
A is Biktarvy, okay.
Good job.
I pass.
Okay, what's
Done.
B?
Paul.
You start Genvoya?
It is not.
Third one's Genvoya.
None of these are Genvoya, guys.
I was about to say, I think
None of them are Genvoya.
Dovato.
One of them is Dovato.
Okay, which one's Dovato?
Yeah.
C.
Dovato
C.
C. Yeah.
C.
Jaluka.
Jaluka's
Doesn't matter.
B.
D.
No,
Jaluka's
Jaluka's taf sparing.
Yeah, it's D.
Jaluka's taf sparing.
Yes.
It's an alpha vir sparing, sorry.
Yeah, Jaluka is D. Someone
D.
said it, I think. E.
Isn't he a combo?
Very good. Okay.
Yeah.
So the second one you guys don't know is Simtuza. It does have places where it's a very relevant med. Dovato, Jaluka, you guys sort out. Those are 2-drug combo pills. And then the last one, dolutegravir does not come in a combo with TAF and emtricitabine, so
Right.
that's a 2-pill regimen, but those are the brand names of the 2 pills involved.
Tivicase alone is dolutegravir.
Yes, yeah. Okay, so
That question brought us back to the fact that not everyone's on Biktarvy.
Right.
exactly,
Right.
exactly.
What should they be?
And there are reasons sometimes to not be on Biktarvy.
Biktarvy.
Jaluka.
Okay, and so now which of these are a recommended first-line treatment option for this patient with HIV never been on ART, his viral load was 1.5 million, and he does not have Hep B.
So,
Okay.
so
Relevant.
2 drug regimens not recommended for the high viral load.
For 1.5,
Correct?
yeah, no.
Right?
That's
So it
correct.
automatically takes off C and D.
Correct.
You could do A or E for sure. Well, you should have one a PI though. Or something
ABE.
ABE.
Yeah, so you guys
Maybe.
basically got it. B is an acceptable alternative. It's just not, my point of this was just making sure you guys know what the actual first line regimens are. And so these are the general first line regimens for ART initiation. It's Integrase are the preferred drug along with NRTIs. And the reason is really they're just very effective. Bictegravir and dolutegravir have a very high barrier to resistance and really minimal side effects. There are some, but not a lot, and not drug interactions. So those are really our preferred class. There is a long list of acceptable alternatives, including PIs and other things. But you guys got it up here. The ones to be aware of with the INSTI plus 2 NRTIs is that dolutegravir, abacavir, lamivudine, which is Triumec. You have to have that HLA be 5701 negative, and you cannot have Hep B. And then dolutegravir, lamivudine, exactly what you were getting at. There's actually multiple caveats for this one, but the high viral load. And you need to know sort of their genotype and Hep B labs. So in reality, I think we'd rarely start someone on the 2 drug regimen because often you don't have, sometimes you do, but often you don't have that information when you are starting someone. Oh.
I was about to say, this might
Great.
bring that up.
That was
So,
great.
I forgot I added this. I don't.
Last moment.
Yeah. So I don't know if Dr. Green's on the call, but I know he had forwarded a press release that made this like big deal and sounds really scary about dolutegravir resistance from a WHO report that just came out yesterday. And you know, the press release is like resistance to dolutegravir range from 4 to 8 to 20%. Which I think we would all agree is not what we've seen in clinical practice, but this is a scary report, right? So I just wanted to, I opened up the report while the other lectures were going on, and just wanted to highlight a few of the key points of data. So this one first was they looked at different countries that sort of screen people who have not started HIV meds yet or are restarting HIV meds and looked for resistance to dolutegravir. That column is dolutegravir resistance. You can see that there's like maybe one person out of all those people surveyed. So in these people, just all comers who were starting or restarting ART, really not much in the way of dolutegravir resistance. And then this is where they start getting into the data that there was some evidence for dolutegravir resistance. And so they took a bunch of HIV cohorts, and in this one, they include about 600 people who had been getting dolutegravir for many years. And almost 94% were fully susceptible to dolutegravir, and resistance was observed for about 5%. Again, these are people who had been on therapy for a while. And then they looked at who among this cohort had dolutegravir resistance, and it was people who had dolutegravir monotherapy. There were trials done looking at that. Don't do it. There was higher rates of resistance developed, or people who were in the 2 drug regimen of dolutegravir plus lamivudine. And I don't know about their NRTI resistance panel in that setting. I think it was also associated. So again, this is not, the population with these higher levels of resistance are not reflective of our general population, I would say.
So U.S. people were not included in the study.
I don't know that they were in that cohort. There were European and Canada countries, but again, these were selected HIV cohorts. So like some of them were recruited for like a clinical trial, like the dolutegravir monotherapy, and then followed. So they aren't like, again, I reviewed this all this morning, so
Sure.
I think I got the general points, but and then this is the one that got those really high numbers of up to 20%.
Mozambique.
And so when you look at it, yeah, in Mozambique, it was that really high number. Most of these groups only included the people in these samples who were virally detectable on a dolutegravir-based regimen. So everyone who was suppressed was not included. So we're looking at the percent of people in most of these who were on dolutegravir and still had a viral load of 1,000 or more where you could do a genotype. And some of these, like that Mozambique group, were like really treatment experienced people, like multiple prior regimens, known drug resistance.
And those people are like people that were like confirmed taking the medication, and that's what, and they still had the uptick, or
Again, as you were presenting while I was giving this, I didn't look through all the caveats about how much they use like dry blood spots or different ways to see how much drug they actually had in them versus adherence. I don't know. So my sort of takeaways from this brief review of the report is that you can get dolutegravir resistance. We need to monitor for it, especially as we're using integrase inhibitors more widely globally, both for treatment and prevention of HIV. As I said, these groups of participants do not really seem to be reflective of our patients. Also, in many of these settings, genotype testing is not routinely available, which is very different. We can send an integrase resistance panel if we're concerned. And so dolutegravir remains very valuable. So yeah, I would not change my standard use of dolutegravir based on this report at this time. That was so. Yeah. Oh, probably have that. Okay. So, why it's not advancing? Okay. Well, here we go.
Before you move on.
Yeah.
How are you guys addressing HLA B5701 consent? Obtaining consent.
What do you mean?
You guys just document it.
When you order.
And I'm asking all the providers, right? Because it's required by the state.
I thought before we see them,
Consent for HLA.
they do the initial intake, which we don't do.
yeah,
What?
yeah. It's Department of Health. We don't do the
We don't
initial
do
intake,
We don't do the intake.
so we don't do the
Yeah.
initial testing. So good question.
Yeah, so
a good question.
there's an intake team that does all the new patients, and they order those tests for that patient.
I see.
Yeah.
I don't think they document that
They consented the patient.
Yeah, like
I've never
that.
seen that
If
document.
it's there, it's buried in clinical documents, I'd imagine.
Yeah, there's a
Scanning.
law.
But why?
That the physician provider must document consent. Just curious. Okay, sorry.
Why is there a law? We'll go there later.
Yeah, it's a genetic test.
It's a genetic test.
So you have to document.
Sure.
It falls under the umbrella.
Florida.
Florida.
This is another case of like what regimen to start in someone who's treatment naive. So this is a 37-year-old man who came to our STD clinic on January 30th for general malaise for about a week or two. And he had been on prep for HIV prevention.
Ooh.
So this is a case. So he had been started on oral prep back in October 2022. I include along the bottom some of his test results just to show he's had a series of bacterial STIs as well. He had excellent adherence to Descovy, and he remained on it in April when he came back for follow-up. He then had gonorrhea as well. He was treated for all of these. He remained on Descovy, but he expressed interest in Apretude. So May 30th, he started Apretude, which is the brand name for cabotegravir long-acting injectable PrEP. He got the first dose 1 month later, which is the standard schedule to start. He got the second dose, and then every 2 months. That's the standard dosing schedule. You guys have an upcoming lecture on PrEP, so labor it. But so his follow-ups were very much on time, and one of them he had syphilis. At all of these, his HIV testing, including a viral load, was negative. And then on December 27th, he missed his dose. He didn't come in, didn't really hear from him. The clinic tried to find him, wasn't sure. His last sexual encounter was on January 1st. He was very clear about that date. It was anonymous, partner with condomless sex, a male partner. And then he saw us at the end of January with a couple weeks of fevers, night sweat, fatigue, headache, just not feeling well. And at that point, we diagnosed him with acute HIV. His rapid test was non-reactive, but his antigen antibody screen was reactive, and his viral load was greater than 10 million, as you can see with acute HIV. CD4 was fine. And just a quick note about the dosing, like the package insert says to do it 2 months like the dose is every 2 months plus or minus 1 week. That last sexual encounter was actually within that week.
Right?
So,
the one missed dose, right?
Yeah.
But still within the window.
Still within the window.
Theoretically.
Theoretically, I mean, I looked into a lot of the data about how long it can stay in your system. It seems like it stays in the system for longer with women than men. You do sort of wonder. I'll show you some of the other data later. So, well, you're up next. So he would like to start ART today. You only have the labs I gave you. Which of the following regimens would be most appropriate to start in this case?
Yeah, I mean, I think what this is getting at is you had a guy on an integrase inhibitor for PrEP and contracted HIV essentially while he was on it. So you probably want to avoid an integrase inhibitor. And he's got a viral load of 10 million, so you don't want to use D. So I would do B on this guy.
Everyone agree? Yeah, that was exactly the part. And the top part is what I showed you before for the preferred first line regimens, but in the guidelines, it actually has these caveats. So like those are the preferred regimens for people who do not have a history of long acting cabotegravir use for PrEP. And there's a whole separate preferred section for if they have a history of cabotegravir long acting injectable PrEP. And it's exactly the regimen you mentioned, pending results of a genotype. And so this is from the curriculum. It's just sort of another way to say it. If someone's had prior cabotegravir exposure, especially recently, you would get not only the standard genotype we get for everyone on ADMIT, but you would also get an Integrase genotype.
It doesn't come in the standard.
Nope.
No.
Not at least at the VA. You have to.
It doesn't at the health department either. Yeah. Yeah. And in the case I showed you, he did not have integrase resistance, which I'll get to. So again, I don't want to steal the thunder from the PrEP talk, but these were the two clinical trials from the HIV Prevention Trials Network, HPTN 083 and 084. They did not have any sort of catchy acronym, so they're just called that. And these are the two trials. The first one was in MSM and transgender women. The second one was just in cisgender women in Africa. And both showed that Cabenuva was superior to Truvada for PrEP, with a significantly lower number of infections in groups with about equal numbers. And so why I mention that is that then they looked at those new infections in the people who had gotten cabotegravir. So this was a follow-up paper. And they looked at people, the trial was ended because of effectiveness. And then so after they unblinded, people could stay on cabotegravir, they could switch to oral, they could stop PrEP completely. And in the 12 months after unblinding, there were 32 HIV infections in people who had gotten cabotegravir. So they split it into had they gotten cabotegravir within the prior 6 months when you would have slightly higher levels, or the longer than 6 months ago. And in those who had gotten it in the past 6 months, the detection of HIV was delayed in 14 out of 18 of those people. They were doing in these trials just like rapid HIV tests. They weren't doing viral loads at every visit. And so the rapid HIV, there's this whole like Levi syndrome with long-acting injectable PrEP where the presentation of acute HIV is different. It's much more mild. You get weird lab results where the lab tests are not as reliable. It takes longer for you to develop a serologic response to the HIV that we can detect with these tests. And that's probably because you're partially treating it with the cabotegravir that is in the system. And in those cases of delayed detection, that's where we saw 10 of those 18 cases had high-level NC resistance. In the other group, where it had been more than 6 months, there was only one case of delayed detection and no NC resistance. So that's why the guidelines of most people currently in people you're giving long-acting cabotegravir to, we're generally checking HIV viral loads like every 2 months rather than just like a antigen antibody combo. Because the thought is if you could have, when they went back and looked at like blood samples they had saved on those people who had the delayed detection, if they had done viral loads, they would have detected it earlier. It would not have been delayed. And so, yeah, that's why. So the guy I presented to you, we clearly caught him very early on. We diagnosed him really early on before he had a chance to develop that integrase resistance. So, yeah.
You get like, if you miss a dose, are you allowed to continue on cabotegravir, or do you have to basically get switched back to like Truvada or something? I mean, at the VA, like if you miss a dose of your Cabotet or your Cabenuva, then you're like we don't let you continue on this. Like we switch you back to oral basically. So I don't know how it works.
I mean, that would be individual protocols.
Yeah.
I don't think we have such a strict protocol at University Clinic at the moment, at our STD clinic, but it's really, I mean, we have one provider who really sees them all, and he makes the decision and he calls me
Case by
in.
case basis.
Yeah, basically.
We're very strict about it just because we don't want people missing appointments and it's expensive and stuff like that. But have we ever had a person miss it? No, the only person who missed it, he died because of non-hypotensive.
So
I hope he didn't.
We're like, he's reliable, why did he miss it? And
We're not
he was-
oncologists, we
went
don't
into
give
surgery
medication.
and he was found dead in his apartment
Oh.
from the cardiac, that, maybe, who knows. And the other person that we switched back to a regimen was that they had LFT elevations. So in theory, we haven't hit
Yeah.
that bridge yet, but
yeah, if you're more than a week delayed, you should start oral prep because of this long, cabotegravir has a very long half-life and can stay in the system for a long time. Yeah. Okay, another case. John?
27-year-old cisgender woman is diagnosed with HIV on routine screening at her first prenatal visit. She is 8 weeks pregnant. She presents today to establish HIV care and start ART. She is hoping for a once-daily regimen. She has never received PrEP. The load is 65,000, CD4 534. Which of the following is the preferred therapy for ART? Initiation in pregnancy and is taken once daily. So, A. That's for sure.
Anyone else have ideas?
Yeah.
John's not calling.
Yeah.
Tarvey. Big Tarvey.
I mean, well, Integrase should be on there, right?
The guidelines have updated, Will.
CBK.
So this, yeah, so we're going to go through their preferred and then the actual approach. So the reasons these other ones are not is that 2-drug regimens make people wary in pregnancy. Darunavir, ritonavir is a BID dosing in pregnancy. Bictegravir has insufficient data per the guidelines, and cobicistat has a higher rate of failure. And so this is the table for ART initiation in pregnancy for people who are treatment naive. And this is just the preferred. There is a long list of acceptable alternatives with careful monitoring, which is basically most of the rest of the regimens. But the actual preferred is an Integrase, specifically dolutegravir plus 2 NRTIs. And if people have a history of cabotegravir for PrEP, it goes back to the PI regimen. But darunavir and ritonavir are BID dosing in pregnancy. So this has changed in the guidelines, which will look at some of the dolutegravir data. It used to be raltegravir. Now there's sufficient evidence, and dolutegravir has a higher barrier to resistance. It's more widely available, so it has superseded that as the preferred regimen. So in pregnancy, obviously, ART is always recommended in pregnancy. You're always sort of balancing any potential risk to the fetus from ART and medications and the compatibility of a regimen in pregnancy. If someone is on ART and becomes pregnant, generally, in most cases, you can actually continue what they're on if they are virally suppressed. You don't want to risk switching and, virologic failure or blips. You can consider switching to a preferred regimen. And some of the topics, as I mentioned and was getting at with that question, things that make people wary are things like 2-drug regimens have very limited data in pregnancy. Most people would probably not recommend those. Cobicistat containing regimens have had increased virologic failure in later trimesters due to lower drug levels and the pharmacokinetics of pregnancy. And then our new agents like bictegravir, doravirine, there's insufficient data in pregnancy and no clear guidance whether to continue or switch. Again, if someone was on that and got pregnant, I think most of us would probably just continue. They're doing well. But that is the actual recommendations in the guideline. And I don't know if you guys remember the issues with dolutegravir and concern for neural tube defects in the past. People used to be wary about dolutegravir in pregnancy. Because of this letter to the editor in NEJM in 2018 on the right, where the country, were they in Botswana? I forget, had switched from an efavirenz-based regimen to dolutegravir-based regimen. So then they were monitoring all babies born, and there were 400 babies. Out of that, there were 4 with neural tube defects, obviously much higher than we typically see. So that everyone was like, whoa, let's figure this out. But then since then, multiple studies and larger number studies have shown that there is no increased risk. This table on the right, the 2 shades of greenish bars are dolutegravir-based regimens, and the purple is efavirenz. And this is the proportion with adverse outcomes. The first one's total, and then it's separating out the different potential adverse outcomes. So you can see that dolutegravir is similar or better outcomes, actually, fewer adverse outcomes than the efavirenz base. So there was initially that concern for neural tube defects. That's been since proven not to be a concern in much bigger studies.
In pregnancy, we've had multiple patients come. They've been on Biktarvy, they get pregnant, and we just continue them on Biktarvy.
Yeah, and
even though
there's limited data, but I think most of us do that.
Yeah, we've done that in clinic.
Yeah, because we just, the general approach is if they're doing well, you don't want to mess with it unless you have a very clear reason that it's something like a 2-drug regimen would probably make me pretty nervous to control. So, and if you're not on the preferred regimen, you can always check more closely. You can check viral loads, every month or 2 per the guidelines. Oh yeah, okay.
A 43-year-old man was diagnosed HIV 8 years ago with a CD4 count of 956 and viral load under 200. He was told he is an elite controller and does not need to take ART. His viral load has remained suppressed over the past 8 years. Today you see him for routine follow-up and note the follow-up in the trend. CD4 counts went from 956, 882 to 642, 10 to 332 in the coming years. What is the best next step in management?
Okay.
I was about to
Okay.
say A as well.
Make the
Viral load,
HIV.
we blame that on the HIV.
All the old studies, I mean, they used
HIV
it
too.
100 to say if it was undetectable, right? All
Correct,
the
yeah.
original.
That's
Mhm.
like the guideline is undetectable under 200, technically, right? By like the HIV stuff, it was like under 200. These are
Not technically, I mean, it's by the limit of detection of the test you're using, but a lot of, if you're trying to compare to a study, some of the
Yeah.
studies looked at it under 200, yes.
Labs are like way more sensitive now than used to be, right?
Yeah.
So,
Has anyone seen an elite controller?
There's one at the VA who keeps no showing. Because
it
his
doesn't need.
viral loads are undetectable and and we've tried to get him into the
Mhm.
clinic, but this past week, and he did get the lab. So I don't even know if he's still as well controlled.
I had one in fellowship who came every 6 months for lab check, but he actually had a pretty similar trend to this, whereas he was getting older, his CD4 count was dropping. And so that did lead to a big discussion of what to do. This question was adapted from one on the HIV national curriculum, and this is the actual recommendation here.
Guys,
I
I
mean-
thought you'd be all over it since it was Biktarvy.
So
Becky was.
So is it because of the drop? Is there a threshold like?
I would imagine it's got to be because of the drop. Because at the end of the day, it's irrelevant what why he's having the drop, especially if there's any viral load to impact that. So if he's getting to the point where it's like you're tipping him over from a low CD4 from another source, you could eventually knock him into. So even if 10% of that loss was due to HIV and the rest was due to something else, eventually he's going to get so low from that other cause that 10% is going to put him over the edge.
There's also other benefits to starting that go well beyond, I'm sorry.
No,
That go well beyond decreasing.
Oh, yeah, but it may be regulation.
Increasing your CD4 count.
Viral load is less than 200, so.
yeah, so this probably wouldn't be a board's question because I don't know that the answer is that well defined, but it does come up rarely. You definitely want to follow these patients, and generally people would start ART if we see signs of disease progression, and that drop in CD4 would probably be enough for me. I mean, it was a substantial drop over the years. And then the big thing that I think Dr. Vega is getting at is that even with low-level HIV without full suppression, there is some level of inflammation and an increased risk of cardiovascular, like biomarkers and associated morbidity, non-HIV related morbidity in these people. The studies are small, but so, you know, it is the challenge, and it is tough to counsel these patients. Like, if we start ART, we can maybe decrease the risks associated with that inflammation, but ART also does have potential side effects. And so over time, and so it is, you know, a pretty tricky conversation to have. In this question, there is no threshold though.
I would argue our drugs are so good now compared to in the past when we were trying to have these conversations, and there was a lot added morbidity with the treatment and stuff.
Yeah,
A
and
lot has changed since Biktarvy.
mine and my patient in fellowship, the first time I saw him, I was like, I think you should start Biktarvy, and he got very upset actually, because he like had been told for years that he was an elite controller and didn't need the drugs, and the drugs would have more side effects than they were worth and things like that. So it was challenging.
Yeah, it is challenging. Like this, the one that from the VA, we multiple attempts to try to get him in clinic because we want to know if he's progressing or not. And I think because they are, you know, they hang on to this, what they were told in the past.
Mhm.
Obviously, nobody's really educated them that the guidelines are changing, that times are changing. It's
Right.
hard to get them back into care.
Yeah.
So the U equals U was based on a viral load of less than 200 or greater than 200, right?
Less than 200, right?
Or
They were considered undetectable if they
less
were
than
under
200.
200, yes.
so it was based on a viral load of less than 200.
Yeah.
Which used to be kind of your undetectable.
Mm-hmm.
I mean, is there any evidence to support in looking at and these patients are pretty rare, so I don't know if they've been able to collect evidence, but that when you start ART, that their CD4 count comes up.
There have been some small studies, if I remember that the CD4 count may go up. I don't know how good the data is. I just remember seeing a sentence stating that in the national curriculum when I was reviewing it. And the national curriculum also divided into elite controllers who have like a viral load below 50, in this case is their limit of detection, versus viremic controllers who have a low level viral load. It said less than 500, but their graph shows less than 200, but it's, you know, more detectable, and those people may be more likely. I don't know that this distinction, again, there's so few of these people, I'm not sure how important this distinction is.
There's no other tests for anything like to say that you're an elite controller other than being HIV positive, undetectable, and
off ART.
I mean, I don't know that they know the mechanism as to why people are elite controllers, so it'd be hard to test without knowing what you're doing.
Like
They have a
CRC,
different,
whatever,
Yeah.
5 mutation
Or see,
in T cells. I don't know.
There are some potential things like that, but I couldn't find one clear answer, and I stopped looking, to be honest.
This is like getting in first place on the initial price. It changes from like CCR5 sometimes to over the CX,
Yeah, that's a different,
right?
yeah. And of course, if over time they lost control and they became virally detectable, like above 200 for sure, people would start ART, of course.
I may have one person that.
I feel like you may have had one.
He was like off ART for years, like 5-7 years.
Yeah.
And finally came back in, he was undetectable. I mean, his CD4 count was like less than 50, but I mean, viral low.
I don't know what to do with that. Okay, in the interest of time, we'll keep moving.
A
Becky?
48-year-old woman has been on ART for 15 years with excellent adherence and viral suppression. 2 years ago, she switched from Favirenz, TDF, emtricitabine, to Biktarvy. She has gained 15 pounds over this time without any changes in her diet or exercise. She asks if her regimen is the cause of her weight gain. How do you respond? Counsel.
D.
I think, yeah. I think
You can't gain weight on Biktarvy.
Yeah,
Probably
you can.
your weight gain. Sorry.
Yeah,
A.
the insties and the TAC.
Insties are.
See.
I know, that's
I'd be
She's
like,
getting old. We're old, late 40s. Oh.
one of those doctors.
So a couple key points about weight gain. Integrase inhibitors are the biggest one. when you're talking to patients, some of the older regimens actually suppressed weight gain. So when people, especially if they switch from a regimen containing those drugs to an INSTI, they may have a combination of like weight gain from an integrase, but also maybe weight gain because they're no longer being suppressed. So it's a little bit tricky to tease out. So for integrases, the mechanism isn't clear. Dolutegravir is generally most associated with the highest weight gain. This graph, dolutegravir is the top thing, green. There's a couple other integrase, an NNRTI and a PI in this graph as well. The general trend is that usually over time, people do gain a couple pounds over the years as you go on, just in the general population. And this one shows about a 5 kilogram weight gain over a year and a half with dolutegravir, which is what, 12 pounds-ish. And generally, bictegravir is thought to be similar to dolutegravir in the effects of this studies. The other thing to note is that TAF in combination with dolutegravir seems to lead to more weight gain. That's the tallest green bar in both men and women, that we see more weight gain in kilograms with dolutegravir plus TAF regimen than a dolutegravir plus TDF. Again, TDF is thought to maybe suppress weight, so maybe they sort of balance each other out. And then the group with the dark brown bars, the efavirenz TDF, I mean, both of those can suppress weight gain. People still gained over time, but
I find it very difficult to manage in clinical practice because sometimes they want to switch ART, and I'm not really sure if that's gonna, make it, make them lose weight. Sometimes it's difficult to tease out the TAF or the INSTI. So, like for example, you could consider doing a 2-drug regimen to eliminate TAF, but is weight loss going to happen, or is their weight gain just going to?
Yeah, I usually counsel people that the idea of changing would be to stop the increase,
Exactly.
not necessarily to expect a decrease. Yeah, because exactly what you're getting at, and it's really hard because they. The guidelines will be like, you should warn people of this when you're starting these regimens. I don't know if you guys routinely warn people, like, I think you could warn them in.
We don't start regimens.
We don't start regimens in different.
Right, but you see people who've been on it for a month or two. That would still be in the time frame of when you could warn them.
Sure. Some people that need it, yes. Something like skin
right.
bone. And I'm like,
that's the thought. Some of it might be catch-up weight gain, but it seems more pronounced in these integrase regimens than others that also lead to viral suppression. So it is a real thing. It's usually a modest weight gain. Not everyone gains weight. Some people could use the weight, but it is a real thing, and it is more in women than men. We see more weight gain. So I think a realistic approach, because you don't want to scare people away from these highly effective regimens, is that this is a great regimen. Very rarely people can, or not very rarely, but sometimes people can gain a bit of weight. So we should also make sure your nutrition, exercise, also those lifestyle things that are really hard to counsel people on in our visits sometimes. Okay. I think you're up.
44-year-old cisgender man presents to establish HIV care. He has not been off ART for 2 years. Has not been off.
No, he has been off.
He has
Sorry,
been
he has
off.
not been on.
Okay. So he's been off ART for 2 years.
Sorry.
Before that, he was virally suppressed on dolutegravir and rilpivirine. So viral load is 500,000, CD4 is 350, Hep B, core reactive. Which of the following is true regarding management of his hepatitis B labs? He has immunity against hepatitis B, no further action needed. He has active hepatitis B infection. He has resolved hepatitis B. You should receive a single dose of vaccine now. So surface antigen is not reactive. So B is out of the question. Resolved hepatitis B infection, nothing to do. Guess.
Your friends can help you too.
Yeah.
Shows they have vaccinated because it's
Vaccinated.
Doesn't have surface.
But we don't have a surface antibody lab on him to make that decision.
That's the anti-Hep B surface.
Yeah, exactly. Is he immune? If it's not reactive, he's not.
Oh, there we go.
Yeah.
Hep B, so
So
vaccine.
It's a little
He's out of the
weird
question.
that he has been exposed to hepatitis B and has a negative hepatitis B surface antibody. So
Right.
I question whether that hepatitis B antibody is actually
Real.
but
So what's this called when people have this pattern of Hep B labs? Have you seen this before?
This is the isolated, right?
Mm-hmm.
Isolated Hep B.
Isolated core. It is the bane of our existence at times. So interpretation of Hep B serology is a nice chart from national curriculum. This is the isolated anti-Hep B core, present in 7 to 40% of people living with HIV based on which study you're looking at. And it's really complicated because it can represent different things. One is a false positive, you mentioned. Another is resolved infection without a positive surface antibody, so either waning protection, but you can't consider people protected. It can be a sign of low-level chronic infection or resolving acute infection where they're in the period where they're switching from positive surface antigen to surface antibody. So most of these people are Hep B viral load negative per the studies, but they could be at risk of reactivation, especially if they're immunosuppressed in another way, they get rituximab or something like that. And if they don't have the surface antibody, they're not considered immune to Hep B. So per the guidelines, what you should do if you have an isolated Hep B core is give 1 dose of Hep B vaccine and then check your surface antibody titers at 1 to 2 months. If it's greater than 100, then you're done. No further vaccine if needed. But if it's less than 100, you complete the series. If you can't do that titer in 1 to 2 months, then you just complete a whole series and check it, which honestly in clinic is often more practical than trying to get people back in the middle to check it and then continue the series. So usually in practice, at least at the health department, we would just try to vaccinate them. But you do not necessarily, again, most of the time the viral load's negative. And so per the guidelines, you do not necessarily need to check a viral load in this guy. And you don't need to add active therapy. Like he's on a regimen that does not have any Hep B coverage. You wouldn't need to add something at this point. You can try to vaccinate him. Again, assuming that he's like liver numbers are fine, which I didn't give you guys there.
Unless, let's say, I'm not fit, he's about to get
right,
like rituximab, but then viral load.
Yes, this is very true.
Can't prove that they're not in that window period then when they're like acute resolving.
You don't know. You generally don't know. So you ideally in these people, you probably just try vaccinating because it's better than just waiting 6 months and repeating to see what your labs show you at that point, Yeah. So most of the time we would recommend just trying to get them protected because the vaccine won't hurt them if they actually are in that weird window period, right?
The question is if they are in that window period, let's say you don't vaccinate them, would you then start them on a like TAF-based regimen? Yeah, right. It's a good question. And it comes up, especially as we're switching regimens or trying to figure out, and sometimes we aren't great at keeping up with our hepatitis screening. So we realize it's been a few years and now we're wanting to switch for some reason. And do we have to cover for it or not? So usually if you can get them, you want to try to get them vaccinated so that then you don't have to worry about it, right? Because if they're surface antibody, core antibody positive, you're generally, unless they're getting some crazy chemo regimen or something, you're probably fine with them not on a regimen for it.
Okay.
Yeah.
Also, an alternative would be like Dovato, because lamivudine has some Hep B, but there's guidelines saying that if because of the intrinsic resistance, then you can actually cause a flare, right? So it's like some activity better than none, or everything more peril by doing that.
Right.
So for all intents and purposes, unless the person is high risk, if they are core antibody positive, you don't necessarily have to target for hepatitis B, but we keep that in mind with our regimens in the event that they eventually have some sort of, suppression.
I mean, most people are going to get started on a regimen, to be honest, that also has Hep B activity. So often it's a moot point, but we don't want to, ideally we try to get them protected against Hep B, right? That's sort of the point of that.
If they don't already have immunity.
Yeah, because that's when it gets tricky. If they've been on ART for a while and then they still are only core antibody positive and that you've tried vaccine and it hasn't worked, and now you're switching regimens, do you still cover or not? That becomes that's tricky. Okay, so just general approach. You want to use, when you have Hep B HIV co-infection, you want to use 2 active agents for Hep B. Our options would have activity against Hep B are tenofovir, either version, lamivudine, emtricitabine. Things to be careful of. Lamivudine or emtricitabine alone has decent rates of Hep B resistance. So lamivudine monotherapy, Resistance develops in hepatitis B at a rate of about 20% a year. And this graph shows that after like 48 months, so by 5-ish years, people, it's like 70 to 90% of people will have lamivudine resistance in their Hep B. So you don't really want to use monotherapy. And entecavir is also an active Hep B agent that we do sometimes use in HIV regimens, but you would not use it alone without also treating HIV because entecavir can cause NRTI resistance if used alone without an HIV regimen. And if you stop ART abruptly in someone who truly has chronic Hep B, they can have an acute flare. So we counsel people. That's also true if people are on PrEP, oral PrEP, and they have Hep B as well as HIV risk factors. Okay, I think I know it's getting really late, so I may just blow through this case. This is a case of someone who's on all the possible ART, and their creatinine goes up a small bit. And so the point of this is that we have some medications that cause a small increase in creatinine because of inhibition of tubular secretion of creatinine. So the creatinine stays in the bloodstream rather than getting excreted. And that's bictegravir, dolutegravir, rilpivirine, and cobicistat. Again, this is a very small rise in creatinine. It should be 0.1 to 0.2, no more, and it should go up in the first month, and then it should stabilize and not continue to rise. But this is a real thing. I mean, I feel like usually in real life, people's creatinine fluctuates, so usually 0.1 to 0.2. I don't know that we really make much of it generally if it's not an ongoing trend over and other things that can cause CKD in HIV. Honestly, if people are on appropriate therapy, often it's their comorbidities, which is the top section, diabetes, hypertension, hepatitis C. There are HIV-associated causes like HIVAN, and then TDF-associated nephrotoxicity that's seen less with TAF. This comes up a lot when people have CKD as it progresses, which meds need to be dose adjusted and which ones do not. So these are some selected options I pulled from the guidelines. It's mostly your NRTIs that need to be dose adjusted and that cause problems. And that becomes an issue when they're in combo pills, because this one gets to here's a bunch of combo pills and which ones need to be adjusted for CKD and which ones have Hep B coverage. So when people have both HIV, Hep B, and CKD, this is where we get into tricky ART situations. All the regimens that have Hep B coverage are not recommended for creatinine clearance less than 30. So in that setting, those regimens are generally not an option. You usually can't do one pill once a day if someone has Hep B and CKD less than 30. So we get really used to our one pill once a day, right? And
And then it's hard to go back.
And then, yeah.
Somebody on 3, they're all liquid.
Yes, exactly, because you get the dosing adjustments. I didn't include them all for the sake of time, but sometimes it starts being every 48 hours. It's not easy dose adjustments sometimes. Which one is this? Oh, okay. Again, you guys have to get to work. So this is another case that we'll blow through, but it's a patient who's on a regimen that includes a booster ritonavir, and he's on fluticasone nasal spray. And he develops weight gain, easy bruising, weakness, mood changes. What's he have? So he has Cushing's. Yeah. And so he had an interaction. Ritonavir and cobicistat are the ones you really have to be careful with anyone on a regimen, including those boosters. With any new meds they have, you should check and make sure they don't interact. Steroids are a big one. It's why, especially our older patients, I often try to get off these boosted regimens because they'll go to urgent care and get steroids, and they have no idea that it interacts. And they don't have to be oral steroids. They can be inhaled, intranasal. They can be joint injection steroids, epidural steroids can all lead to this interaction.
Topical?
Topical has been reported in case reports. Yeah. Other common interactions with our boosters are PDE5 inhibitors, so sildenafil. Make sure you give people lower doses if they're on a booster. DOACs, a bunch of other meds. These boosters are really problematic for interactions, though. And one random interaction is that dolutegravir can increase metformin levels, so you shouldn't give them more than a gram a day. But mostly if a new med is added and you are not super familiar with it, check interactions. I check it while you guys are precepting with me sometimes if it's something I don't routinely use. because I by no means memorize interactions. Okay, this is the final case, and I think it's a really good one. So I do want to go through this one a little more carefully, and then we're done. So this was presented at ID Week in the Challenging HIV Clinical Cases session. Others of you may have been there. But this is a 43-year-old woman. She was diagnosed long ago. She's not been very adherent over the years, and she's had many regimens. She's been on basically all of our standard classes in different ways. We don't know which of those regimens she's failed or which one she just stopped taking, why the reasons for all the switches. But she's currently on a regimen where her viral load is 50, which is the best she's ever been. She's on dolutegravir, rilpivirine, TAF, FTC. There's a lot of reasons she cannot adhere well to medications, but she has been able to attend her visits regularly. Her BMI is 32. She doesn't have any other medical conditions. And today, because of her struggles taking ART, she's really requesting long-acting injectable medications. So, for someone who wants to start our long-acting injectable ART of cabotegravir, rilpivirine, what do you need to know about them, or what do you guys think about checking? Hep B.
Suppress viral load.
Suppress viral load to start. Yep. Did you say something?
Well,
Genotypes, genotypes, prior genotypes.
Resistance to
how adherent is she to her follow-ups?
Yes, that's important too. I didn't include the genotypes, but you are supposed to be a suppressed viral load for 3 to 6 months. There are case reports of groups trying it in people who are not suppressed, but that's not per guidelines. You can't have Hep B. You shouldn't have known treatment failure per the guideline. You shouldn't have known resistance to the agents in the regimen, and you should be able to come back for every 1 or 2 month visits. That is key. So this was her genotype that they presented. She was subtype B. She has a lot of resistance to NRTIs, but Nofavir susceptible. She's an M184V. And then her NNRTIs, she has some resistance to some NNRTIs, but her rilpivirine is susceptible. Which one of these do you guys do?
This was her genotype long ago.
The most recent one we have. It's the one they presented at IDB.
Isn't she resistant to amphetamine?
That's the regimen she's on that she's doing well on.
She's oh, interesting.
Mm-hmm.
Well, usually when you're using that and they have a resistance in one of the drugs, it's because you're trying to use the other drugs in there in combination with something else. So we know it's useless, but there's no other way to get the other two.
Can you go back to the resistance?
So
And I can show you guys what the options were that the group at ID Week selected, the audience. So the audience mostly said they'd start Cabenuva. Others would switch to Biktarvy. And a small number would keep the same regimen.
A and B.
Or basically continue, and one's like try to support her, and one's like just let her be.
That can't be either of those. You can basically eliminate both of those.
that was a great choice.
So then this is not, I mean, this was the clinical cases. They like have a panel of experts they're asking, and they put the question up, and everyone in the audience gets to vote, and then they ask the panelists. So it's not like a board style question. But yes, I get what
you can pretty much eliminate both those options.
Yes. Yeah. Basically, they were trying to get you to decide between these middle two. Okay. So she got switched to Cabenuva. Some of the panelists were a bit nervous about this and had said before we were told what they did that they wouldn't do that because of her extensive NNRTI experience and her resistance to other agents in that class. She did get it. They drew labs at her 1 month visit. So this was just a month in. And this, they did proviral testing. I don't know why they could have done regular, but she's rilpivirine resistant. So it still showed susceptibility to her Integrase. It had only been a month, so hopefully she's okay with that. She was switched to Biktarvy at this point. I don't know that we got a follow-up from there.
The whole resistance pattern changed.
And why is that?
Because different things were being suppressed in the wild.
Yeah, you need the selective pressure, right? We'll talk about it in clinic tomorrow. Just because we're out of time.
Yeah, sure.
Okay. Yeah, I talked about in a lecture last year, so it didn't repeat. But So risk,
BMI was also, I think,
her BMI was 32. Yeah. And so this is like, these people did modeling, or basically took a bunch of people who, a small number. So there were 1,600 people in all the clinical trials, like 1.4% failed. So then they looked at what was more common in those people who failed. And so when they went back and tested samples for rilpivirine resistance on proviral genotyping, that was not available at the time people were recruited to these trials. If people did have rilpivirine resistance, they were more likely to fail. Shocking. If they had certain HIV subtypes that are less common in the US, they were more likely to fail, and then a BMI above 30. And the bottom bullet point shows the more of those you have, the more likely you were to fail. BMI was a small risk factor compared to those other two. But again, if people have any NNRTI resistance, I think we'd be very hesitant based on some of the data we've seen. So that's what we've covered today. So
Wow.
sorry it's late, but thank you guys.
That was